Hey, welcome back to MobilityWOD. Special guest star today, Jenny Labaw. What we wanted to do was take a second to create a quick template that we think that everyone should know, specifically the physicians, and this was actually a request given to us by a physician, emergency room physician. People are coming in with kind of non-specific low back pain. They have tweaked their back and they don't know what to do. And so what we want to do is create a basic template based on very simple household items or items that you could get at Walgreens very quickly. And so when we start about this, when people have gone to the ER traditionally for a kind of spasm or when they're shut down and they can't move, what we need to be thinking about is sort of two things. And the first is, if you're in a bad position or you've got a little tweak going on, most of the faults that we see around the spine end up being this obliquity around the pelvis. We get a little rotation around the pelvis. And one of the first and easy things to do is to replace that or normalize that mechanics around the pelvis. And that's very, very simple and can be done very safely by the patient, by ourselves. And so we've talked about this before, and I call this a pelvic fault, but understanding that I'll never be able to sort of address a spasm or sort of a pain gate mechanism as long as I'm in a bad position. So our rule of thumb is if something's in the wrong position, put it in the right position. And you can check this or not check this. And what we've talked about before in the past is if someone comes to you, one of your friends and family, there's a couple easy things you can do. And the first is that you can assess if this person's in a good position or bad position relative to their bony alignment by looking at a couple simple landmarks. The first landmarks are right here, the top of the pelvis, this anterior superior iliac spine. And so if you just come, I'm on top of the pelvis here, and I drop right down and there's a little bony spot, as soon as I can equalize my thumbs, I can see a point of reference relative to each side. And what we'll see is that it's very obvious when one thumb or one side is higher than the other, and you don't need to test anymore else. There's a lot of information as a physical therapist or as a chiro that you can use to decide which way it's rotated, which way to fix it. But if you see that the bones are uneven, then you're out of position. Turn around for me, Jenny. In the back, we have the anterior or posterior superior iliac spine, which is right here. And again, I should have two equal landmarks. So kind of those dimples that you see in the back. Both of those things should be even. And then we've talked about on the MobilityWOD about how to assess whether or not they're moving or not. But once again, if I'm level in the front and level in the back, that's not a problem if I'm unlevel on either side. So the first thing we'll do is teach the person how to correct themselves, and they can do this as many times as they want. So you just get on your back, Jim. So what we do here is we get the patient or the tweaker on their back, the tweaker, and all we need to do is have them bring their knees to neutral. And what's great about this position when we're kind of retreating or repositioning is that it's very non-threatening. We've taken all the load, all the axial load out of the spine can sort of relax, and this is actually a position of sort of repose where we've taken a lot of the load out. So if I put my feet up on the couch, I've basically taken a lot of the shear loads out of the spine around the iliacus, the QL, the psoas, and this is one of those positions where my spine cannot feel like it's in spasm and pulling worse. So what we have the patient do is work on mid-range, and what we're going to do is one person, she's going to put her hand on one knee, and the other one's going to push. And what's going to happen now is at first we're going to take a big breath in the belly, and exhale, and on the exhale we're just going to build a nice easy contraction, pushing and pulling. What happens when she pushes and pulls, and she does that for about 5 seconds, not peak effort but just some movement, is that she's using the sort of anterior musculature here and the posterior musculature here to reposition the pelvis. So she goes one direction, and here's the key. The reason we don't care about which way it works is that you won't make it worse. You'll just won't do anything. So if it's the other way, we have the rotation, then so she can push and pull the other way too. And what we tell our patients is we don't want you to worry about what side's which, we want you to do both sides. So she takes a big breath in the belly, exhales, and on the exhale, I can just breathe out for about 5 seconds, keep breathing. We don't want you holding your breath, we want you to breathe out and just do that easy isometric contraction. Once you've done 3 or 4 rounds of both directions, then feet go down, and you can take a pillow or a ball and you're just going to squeeze. One more time, big breath in the belly, She exhales and then squeezes here, and oftentimes we'll get an audible reduction. A physio sometimes will just block, go ahead and take a deep breath and squeeze, and her adductors fire up, very strong. And what we're using is her musculature to reposition her pelvis. And even if we don't get an audible click, and oftentimes we'll get a clonk back into position, and people are like, oh, I'm back. Even if not, because we're in spasm, the musculature is holding us out of position. By repositioning constantly, we'll start to normalize that shape and move us towards optimal, which is normal pelvic function. So a person can do this 3 to 5 to 7 times a day, and we both have had experience with this with family members. Okay, so that's rule number 1, first step. The second thing we want to do is we want to get the musculature around the spine turned off. What your nervous system does is that when it's in full spasm effect, it will basically turn on everything that moves it into a cable to stabilize it. And specifically, we'll see that psoas will get very, very tight. We just did a lot of training around these tissues, right? Iliacus will get super tight. These are the quads of the back. In the back, we get the QL, which is like the hamstrings of the back. When these muscles are literally in spasm or breakdown, and we can't see what's what until we start to address them. So one of the problems that we see is that when people come in, they've got the I can't breathe kind of MO, right? And what you're seeing is you're trying to create intra-abdominal pressure to stabilize. We've got to restore that breathing mechanism and turn off this tissue. Now, we can do that a couple ways. In the ER, they tend to do it with pain meds, right? We can break that spasm with pain meds. Antispasmodics, we can do it sometimes with electricity. But one of the easiest ways to do it is using a neuromuscular technique we call contract relax. And all we have to do is build some tension into that tissue that's already contracted, and then relax like a light switch going off, and by repeating that we can basically get it to turn off. And the easiest way to do that on your stomach is on your stomach with a very, very soft ball. This is a ball from like Walgreens, right? They're very inexpensive. You can pick one up on the way home, and then she's just gonna put that right in her belly. And once again, we're in a very safe position. And here's the deal. What she's gonna do is try to breathe into the ball. We've got to restore that normal function, and the easiest way to tell your system to downregulate is to access that parasympathetic nervous system is through abdominal breathing, is through diaphragmatic breathing. So we've got a lot of systems working here. Or she can take a big breath into the ball, which gets diaphragm excursion, and then she contracts, resist, 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 into the ball for a few seconds, and then release. And then let the ball travel a little further. This is a technique popularized by kind of yogi fascia model genius Jill Miller, but this contract, relax into the ball around the abdominals is a fantastic way to start to restore function in the trunk so that we can tell that spine, hey, it's not in threat. We've resolved your pelvic dysfunction. And number 2, we can get you to start contract relaxing. And as soon as we address this, a lot of times in conjunction with the repositioning, we've broken the dysfunction. The second piece of that, so you can stay on that for 5 or 10 minutes. And the second piece, Jenny, go ahead, put your feet up on the box here.
On my back?
Yep. Is that I've got just a baseball here. This is actually a lacrosse ball and a softball. You can pick these up anywhere. But once again, Jenny is in a position where with her feet up in this sort of 99 position, we've taken all the load out. So she can start working on diaphragmatic breathing. We can start to normalize. We can say, hey, your spine isn't under threat. Then she can take this ball, drop it in right underneath. Now we're looking for that kind of QL, which is the back strap muscle that goes from the top of the rib cage, or bottom rib cage, top of the pelvis. And then she's just gonna come into the side. And again, when she finds that it's in rock lockdown, she takes a big breath, contracts on it, wait for 5 seconds, just resisting, and then release and let the ball enter. And what ends up happening, yes, these QLs get tight anyway, but what we find is that in people who are in spasm about a pelvic tweak, if we can restore the motion, reposition, then what we start to get is get out of that pain cycle, which is the first step in restoring function. Then we can start to see what's going on, and then we can start addressing the dysfunction or the obliquity or some other things, or the dysfunction that was leading to that obliquity in the first place, right? So three kind of key things that everyone should know, because you're gonna tweak your back in the backcountry, you're gonna tweak your back on vacation, you're gonna tweak your back on the mission, and everyone should know that first, hey, you're out of position, let's see if I can put myself back in position. 2, Let me turn off the spasm and restore the function. And then I can start to just get some motion around my pelvis. And then even just going for a little walk. Hey, I feel better, great, let's go walk. That easy motion starts to tell your brain you're no longer a threat. Those 3 things is sort of our base template for self-treatment around pelvic dysfunction in a pelvic tweak, non-specific low back pain. Jenny Labaw, MobilityWOD, see you tomorrow.